Hello everyone and welcome to another video of Cardiology Fundamentals. My name is Abdulhamied Alfaddagh and I'm a cardiology fellow at Johns Hopkins. I'll be giving you a quick summary of how to manage patients with acute chest pain and suspected acute coronary syndrome. So let's start. Chest pain is a common presenting symptom of disorders that can range from trivial to life-threatening. There are many causes of chest pain, but it's best to think of the differentials according to organ systems: cardiac, pulmonary, gastrointestinal, musculoskeletal, and others. Within each of these categories, there are a couple of life-threatening diagnoses that you must not miss. These important life-threatening differentials are shown here in red. These are acute myocardial infarction, aortic dissection, pneumothorax with or without tension physiology, PE, and esophageal rupture. When you're evaluating a patient with chest pain, your approach should be efficient and executed in a timely manner. This involves obtaining a focused history and a targeted physical exam, as well as obtaining a 12-lead EKG. These three components should be completed within the first 10 minutes. The goal of doing so efficiently is to answer two key questions. The first is whether the patient is clinically stable, and the second is whether the patient is at risk of a life-threatening illness. Answering these two questions will allow you to categorize your patient with chest pain into three categories according to acuity and move forward with your management. So let's say you get called to the bedside because your patient is experiencing chest pain. While on the phone, you can actually start by asking for three things as you move towards the patient's room. These are a full set of vital signs, a 12-lead EKG, and ensuring the patient has appropriate intravenous access. When at the bedside, a focused history is key. It's important to be systematic and cover important historical elements. Back in med school, I used a mnemonic called Socrates, which is shown here, but honestly, you can use whatever you want. Just be systematic and avoid anchoring in your thought process. Symptoms suggestive of ischemia are seen on the left column, whereas features which may suggest against ischemia are seen on the right. It's important to note that the best predictor of whether the pain is likely from ischemia or not is the global description of the pain, more than any of the individual components on its own. Some descriptions on history may suggest an alternative diagnosis. For example, sudden chest pain makes me think of acute aortic dissections, pulmonary embolism, or pneumothorax. Now pause this video for a moment and take a look at the different features listed here and the diagnoses you should be thinking of. It's important to be aware of the patient's comorbidities, since that affects whether ACS is likely or not. For example, age is a very important factor to account for, and acute chest pain in older age adults should always make you think of acute coronary syndrome, even when the pain description may not be classical for ischemia. Asking about prior history of MI, stroke, or peripheral vascular disease is simple yet very informative. And in patients with diabetes or CKD, who have higher risk of CVD, I'm usually more worried about any kind of chest symptoms in this population. Patients with higher number of risk factors have higher risk for ACS, and recent travel might alert you to the possibility of PE as the cause of pain. After taking a focused history, I usually perform the targeted physical exam. Abnormalities in the vital signs usually indicate the severity of disease. For example, hypertension often occurs after a significant MI, aortic dissection, or PE. And bradycardia in patients with chest pain makes me think of an RCA territory ischemia, which supplies the AV node. You should always get in the habit of taking blood pressure measurements from both arms and compare. A discrepancy between sides might indicate acute aortic dissection. Moving to the neck, an elevated GVP is seen in acute heart failure, PE, or pericardial tamponade, and tracheal deviation suggests tension pneumothorax. Listen to the patient's chest for murmurs such as the murmur of acute mitral regurgitation or a ventricular septal defect. And note that unlike other cardiac conditions such as valvular heart disease or acute heart failure, patients with acute coronary syndrome have only a few or no physical findings unless a complication is also present. So what are some of the indicators of worse prognosis on history and exam in patients with acute coronary syndrome? Hemodynamic instability, such as hypertension or tachycardia, are often early signs of cardiogenic shock. Any evidence of heart failure on exam is always worrisome. Persistent chest pain, delayed presentation, or patients who are at high risk of bleeding all have worse outcomes. After your focused history and physical exam, immediately focus your attention on the 12-lead EKG. The EKG is a major branching point in your decision-making, and obtaining an EKG early is very important. The objective is to identify diagnostic findings suggestive of an ST elevation myocardial infarction as soon as possible. If your patient has chest pain and diagnostic ST elevations, then you have adequate clinical likelihood of a STEMI to act upon these findings. Let's talk a little about what an ST elevation looks like. The height of the ST segment is calculated from the initial onset of the Q wave, which is shown by the first arrow, up to the J deflection point, which is shown by the second arrow. ST elevations may take several shapes. The four shapes on the left of your screen suggests ischemia in the appropriate clinical context, while the pattern seen on the right might be seen in other conditions such as with acute pericarditis. ST elevations suggestive of acute myocardial infarction occur in two or more contiguous leads. The cut point for what is considered an ST elevation is 1 mm or greater in any lead except for V2 and V3, which have a gender and age-specific cut points. If the pain is intermittent, it's important to obtain an EKG during pain and another one when the pain resolves. It's also useful to compare new EKG changes to old EKGs, as this will increase your diagnostic certainty. So if you're able to recognize diagnostic EKG findings suggestive of a STEMI, then the cath lab should be activated as soon as possible. Hospitals and emergency rooms have well-defined mechanisms to activate the cath lab and get cardiology on board quickly. On the way to the cath lab, adjunct therapies are given, including oxygen supplementation when needed, dual antiplatelet therapy, nitroglycerin, and heparin, and we'll talk about these therapies shortly. The goal is myocardial perfusion resulting in myocardial salvage, and this is where the phrase time equals muscle is often used. Any delay in reperfusion adversely affects patient outcomes. The commonly quoted figure is that every 30 minutes delay to PCI increases 1-year mortality by 8%. The target is to achieve mechanical reperfusion in less than 90 minutes from ED presentation in PCI-capable hospitals, and when PCI cannot be achieved within 120 minutes, then the goal is to achieve pharmacological reperfusion with thrombolytics in less than 40 minutes. In this patient with chest pressure, you can see ST elevations in the anterior lateral leads with reciprocal changes in the inferior leads. This is consistent with an acute anterolateral ST elevation MI. In the next 4 EKGs, pause the screen and write down your diagnosis. We will reveal the answers after the 4th EKG. This is an EKG of a 32-year-old with acute pericarditis. Compared to the EKGs we just reviewed, you can see that the ST elevations here are diffuse and not localized. The ST pattern is concave, unlike the prior EKGs, and there are no reciprocal changes. You can also see PR segment elevation in lead AVR, which is classical of pericarditis. Okay, what if my patient's EKG does not show findings of a STEMI? Then I have a little bit more time to think about other differentials. What is running through my mind is a triaging process to exclude other life-threatening diagnoses. The EKG is still useful and might actually hint to the underlying process of chest pain. Some of the findings you want to look for include ST depressions and others such as new pathological Q waves. With the left bundle branch block or paced rhythm, ischemia may be hard to define. In the setting of a left bundle branch block, the Scarboza criteria may be used to indicate the likelihood of MI. A little about ST depressions. Unlike ST elevations, ST depressions are non-localizing. They come in 3 flavors according to the slope of the ST segment. New horizontal or downsloping ST depressions greater than or equal to 0.5 millimeter in 2 contiguous leads are suggestive of ischemia in the appropriate clinical context. Here is an EKG of a patient with 3-vessel disease presenting with ischemia. You can see the diffuse horizontal and downsloping ST segment deviations and poor R-wave progression. Also note that AVR is elevated, and that usually reflects the widespread ST depression. Another important finding are these deep symmetrical T-wave inversions. When these are present in the setting of acute chest pain or acute coronary syndrome, Whelan syndrome is said to be present and suggests a proximal LAD stenosis. Other conditions which may have similar EKG findings include acute stroke and stress cardiomyopathy. Here is an EKG of a woman with chest pain. The EKG shows sinus tachycardia together with the classical S1Q3T3 and an incomplete right bundle branch block. These findings, although non-diagnostic, are suggestive of pulmonary embolism in the appropriate clinical context. A common question is whether a normal EKG excludes ACS. The answer is no. The EKG may be silent during ischemia. It's important to note that if the suspicion for acute coronary syndrome is high and the EKG is silent, it's often useful to obtain posterior leads and right-sided leads to identify lateral and RV ischemia. Let us move to the initial management of patients with chest pain. It is important to note that the treatment starts early as the diagnostic workup unfolds. You can start by ensuring continuous bedside monitoring and vital sign recheck. Aspirin is effective across the spectrum of acute coronary syndrome. In patients with no contraindications to initial aspirin, such as those with active or recent GI bleed or true aspirin allergy, a full dose of non-enteric coated aspirin chewed is best to achieve early therapeutic levels. Sublingual nitroglycerin could be given in patients with no obvious contraindications, such as inferior wall MI or RV infarction, hypotension, marked bradycardia or tachycardia, recent phosphodiesterase inhibitor use. If chest pain continues despite the first sublingual nitro tablet, you might give up to 3 sublingual tablets 5 minutes apart until the pain resolves. If chest pain is still present, you may start an IV nitro drip. O2 supplementation is recommended if hypoxia is present. The initial focused workup of patients with acute coronary syndrome includes obtaining cardiac biomarkers for confirmation and risk stratification, obtaining a chest X-ray for excluding other causes of chest pain, and obtaining a CBC and a basic metabolic panel. A stat chest X-ray should be obtained within the first 30 minutes from presentation, but should not delay reperfusion therapy unless clinically indicated. For example, when there is high suspicion for acute aortic dissection. In that case, a chest X-ray is useful. As in the first X-ray on your left, acute aortic dissection may present with a widened mediastinum. Chest X-rays are abnormal in 75% of patients with acute aortic dissections. However, it's important to note that a normal chest X-ray does not rule out aortic dissection. Chest X-rays may be useful in detecting tension pneumothorax and pneumonia. Although I did not include this here, but patients with esophageal perforation may also have distinctive chest X-ray findings. In patients with symptoms of myocardial ischemia, a rise or fall of troponin confirms the diagnosis of myocardial infarction. Note that you are more likely to detect a rise or fall in troponin when blood sampling is either early or very late, respectively. Sampling close to the troponin peak has lower chance in detecting a change in troponin level, in which case a third troponin check is needed to confirm this pattern. It's important to note that the initial troponin level is predictive of higher risk, since it might indicate a late presentation. A common question asked is whether troponin levels can differentiate the mechanism of myocardial injury and accurately distinguish between type 1 and type 2 MI. The answer is no. A good example of why this is the case is the graph combining data from 4 different studies comparing troponin concentrations in patients with type 1, type 2 MI, and myocardial injury. As you can see, although type 1 MI tends to have a higher troponin level, there is a significant overlap in ranges which limit the accuracy in differentiating between etiologies of myocardial injury. I want to highlight now other causes of troponin elevation other than acute atherothrombotic MI, which is also known as type 1 MI. Pause this video for a moment and take a look at the different conditions listed here. There are a couple of useful investigations beyond your initial focused workup that you might want to pursue based on your suspicion. PE can be safely excluded in those with low likelihood of PE by demonstrating low D-dimer levels. If the suspicion for PE is high, then a CTA of the chest or a BQ scan is indicated. If the clinical presentation is suspicious of aortic dissection, then a stat CTA is the test of choice because of its quick and non-invasive nature. An alternative is a STAT transesophageal echocardiogram. Lastly, the use of coronary CTA is growing when triaging chest pain in patients with negative biomarkers and low risk. Since PE, aortic dissection, and acute coronary syndrome are often thought of together in patients with chest pain, some EDs have developed a combined CT protocol to rule out all three in one CT of the chest. That is often called a triple rule-out CTA. Compared to a dedicated CTA of the coronaries, a triple rule-out has less spatial resolution and higher contrast and radiation use. Now that we have a good understanding of the patient's symptoms, EKG, and biomarkers, and have thought about the non-ACS life-threatening differentials, the goals moving forward is to risk stratify your patient with ACS and offer therapy. Ischemic risk assessment with scores such as the TIMI or GRACE scores will help decide whether urgently going to the cath lab and defining coronary anatomy is needed. Red flags, such as the one seen on the screen, should push for an urgent invasive rather than an ischemia-guided strategy. The early goals are to reduce ischemia, reduce thrombosis through providing adjunct therapies such as anticoagulation and additional antiplatelets, improving pain, and detecting complications. Identifying and correcting reversible causes of ischemia is important. This includes addressing tachy or bradyarrhythmias, lowering blood pressure in hypertensive emergency cases, improving anemia, and others. Nitrates reduce cardiac work by reducing preload and increase myocardial blood supply by dilating coronary arteries. Unfortunately, nitrates cause reflex tachycardia and therefore are best used with beta blockers. Beta blockers reduce mortality. Oral beta blockers are preferred over IV beta blockers given the risk of acute cardiac suppression. However, IV beta blockers may be used with caution in patients who continue to have chest pain despite IV nitrates. We generally like to start beta blockers in the first 24 hours if there are no contraindications. If bleeding risk is appropriate and acute aortic syndromes are unlikely, anticoagulation should be started in conjunction with antiplatelet therapy as soon after the diagnosis of ACS is made. This is for patients with ACS irrespective of management strategy. Unfractionated heparin, low molecular weight heparin, fondaparinux, bivalirudin all have been associated with a reduction in ischemic events in acute coronary syndrome patients. The choice of anticoagulant is based on the treatment strategy as shown here. If no PCI is planned, anticoagulation is continued for 48 hours. Generally, anticoagulation is discontinued post-successful revascularization or after the exclusion of a type 1 AMI. But there are exceptions to this rule, and the interventionalist can help recommend an anticoagulation strategy if indicated after PCI. Holding warfarin or DOACs is often required prior to invasive angiography, especially in non-urgent cases. Operators may have different preferred cut points for an acceptable INR prior to undergoing invasive angiography with or without PCI. DOACs pre-procedural hold times are based on procedural bleeding risk, type of anticoagulant agent, and renal function. In addition to aspirin, clopidogrel, ticagrelor, and prasugrel are commonly used P2Y12 inhibitors. There's a fourth P2Y12 inhibitor called cangrelor, which has specific indications that are beyond the scope of this talk. These agents should be started soon after the diagnosis of ACS, irrespective of management strategy. Prasugrel is preserved for those undergoing PCI and is contraindicated in patients with history of TIA or stroke. Clopidogrel has the least bleeding risk compared to ticagrelor or prasugrel, but is less effective in preventing ischemia events. I want to highlight a couple of points around antiplatelet therapies in special populations. To date, there are no clear guidance on antiplatelet therapy adjustments when thrombocytopenia is present. Generally, in the absence of bleeding, a platelet count of less than 100,000 is clinically relevant. Clopidogrel is generally preferred in patients with thrombocytopenia if a non-invasive approach is chosen. In patients with acute myocardial infarction who are scheduled for surgical revascularization with coronary artery bypass grafting, a washout period prior to surgery reduces the risk of perioperative bleeding. Persistent ischemic chest pain despite medical therapy is a poor prognostic sign and informs the urgency of management and cardiac catheterization. Chest pain should be first controlled by reducing demand and improving coronary supply as much as possible. Your initial strategy should not be masking ischemic chest pain with sedation or opiates. I list here 3 scenarios where the use of morphine is appropriate. Morphine reduces preload and therefore should be avoided in patients with hypotension or preload-dependent states. It also slows GI transit and reduces antiplatelet absorption, and this should be taken into account when loading with dual antiplatelet therapies. It's important to triage chest pain patients to units where they can get appropriate therapy. The risk of arrhythmia guides this decision. Serial troponins help establish the diagnosis, and a peak troponin often correlates with the extent of myocardial injury. Serial EKGs are important to detect potential complications such as complete heart block, and may also indicate structural changes such as the development of LV aneurysms. Lastly, adding high-intensity statin is very important early in the course of therapy in the absence of contraindications. Similarly, the administration of angiotensin-converting enzyme inhibitors or angiotensin receptor blockers early during the course of acute myocardial infarction prevents long-term major adverse outcomes and LV remodeling. In your care of patients with chest pain or acute coronary syndrome, you can reach out to your colleagues from cardiology at any time. Examples of when urgent extra help from cardiology is needed include the development of ischemic symptoms, arrhythmias, or any signs of pump failure. Finally, I hope you found this short talk useful. For additional useful content similar to this, don't forget to subscribe to the CardioNerd's YouTube channel and podcast, and hit the like button. Stay safe, everyone.